Hello, everyone. Thank you for joining us for this interesting topics. And I wanted to thank the New Jersey American Academy of Pediatrics for the partnership with HMH to make this talks possible. And today we are going to hear pediatric endocrine topics. And I'm proud to introduce our speakers for today, right? So we're going to hear about precocious puberty by Dr. Alexa Durante, who she, after doing her residency at the Jersey Shore University Medical Center, joined Montefiore Medical Center for a fellowship in pediatric endocrinology. And then subsequently, she recently joined us back, and we're very happy to have her with us. Even though she will speak to us about puberty, which is a very important topic for a pediatric endocrinologist, I know she has a lot of other interests, including quality control, diabetes, and inequalities, which I would personally love to hear more about in the future. So, welcome, Alexa.
Thank you.
It is with pleasure that I also want to introduce our first speaker, which is Dr. Shoshana Tell. Dr. Tell will talk to us some aspects of type 1 diabetes, which, as you know, is very important for pediatric endocrinology and something that is very close to Dr. Tell's heart. So Dr. Tell did her pediatric residency and medical school in the New York area. And then she went to the Children's Hospital in Colorado, where the Barbara Davis Center for Diabetes is located. And for all of you that you may not know, probably the Barbara Davis Center for Diabetes is the place of excellence in the world, probably the first. There's children with diabetes from all over the world that come there, where she spent 3 years learning how to do excellent diabetes care, which is what she's doing with us after she joined us in 2021. It is my pleasure to introduce these both speakers and to be here with all of you. Thank you.
Thank you, Dr. Eisenberg. So I'm Dr. Shoshana Tell. I'm the Director of Pediatric Diabetes here at the Mali Center for Children with Diabetes in Hackensack. And today I'll be talking about the identification and management of early type 1 diabetes. Next slide, please. So I'm sure that many of you are familiar with the classic presentation of new onset type 1. So I'll walk you through an example patient, which is a story that I'm sure that you've all seen before as pediatricians. So John, a 10-year-old male, was previously healthy. His mom has a history of Hashimoto's, his father, hypertension. In the evening prior to coming to the hospital, he went out to a new restaurant for his mom's birthday. The next day, he woke up and he unfortunately was vomiting and had severe abdominal pain. At first, he assumed that this was maybe food poisoning from a new restaurant. However, by the end of the day, he continued to have persistent vomiting, and he and his family were concerned that he was getting dehydrated, so he came into the emergency room. In the emergency room, he was found to have severe diabetic ketoacidosis and new onset type 1 diabetes. He went to the pediatric ICU where he was treated with an IV insulin drip. And after the DKA was corrected, he was then transferred to the inpatient pediatric floor for new onset diabetes education. John and his family dealt with a lot during this time, feelings of shock, grief, exhaustion, and trauma, him going from being a healthy 10-year-old to suddenly being very sick in the ICU. His hospital admission also lasted between the ICU and the floor about 5 days. So it was really a lot for him and his family. So what if I told you that we could have prevented this? So if John had access to early type 1 screening, he could have had an alternative diagnosis story. So here I take you to what could have been John's story if, say, 2 years earlier when he was 8, his pediatrician had done early screening. So John, at that time, a healthy 8-year-old, came into his pediatrician's office for his annual checkup. The pediatrician reviewed family history and noted that mom had a history of autoimmune disease with Hashimoto's. His pediatrician was quite astute and decided to encourage him to get type 1 diabetes antibody screening, despite the fact that he had no signs or symptoms of high blood sugar. When the results came back, they found that actually 2 of his type 1 antibodies were positive, although he had a normal hemoglobin A1C at that time, and again, no concerning signs or symptoms for hyperglycemia. At that time, the pediatrician referred him to pediatric endocrinology, given his positive antibodies. So what happened next when he came to pediatric endocrinology? So in the endocrinology office, they did repeat testing to confirm again that he had 2 positive antibodies. He and his family received gradual diabetes education over time, learning how to check blood sugar and ketones, and they were able to process it over a longer period of time. He also had close blood sugar monitoring. And so at age 10, when gradually blood sugar started to increase and he had persistent hyperglycemia, he and his family were very prepared and educated when it was time for him to start on subcutaneous insulin injections. And this teaching did not require admission to the hospital. And again, the family felt prepared with 2 years to process that this was coming and learn more about type 1 diabetes. So this example leads us to the many benefits of early type 1 diabetes detection. So most importantly, it can really serve to prevent DKA at presentation. Numbers vary, but in general, the rate of DKA at new onset of type 1 is anywhere between 30 to 50%, depending on the institution. However, in those who are enrolled in monitoring programs after being detected early on with positive antibodies, there's only a 5% chance of DKA at presentation, so significant reduction. We know that, of course, DKA itself can have a lot of adverse medical outcomes, and it also predicts poor long-term glycemic outcomes as well. Again, with early detection and education, we can prevent hospitalization and also empower families to have the choice to participate in various research studies, as well as potentially have access to teplizumab treatment to delay the progression of type 1 diabetes. So when we talk about the progression of type 1 diabetes, I wanted to walk you all through the stages of type 1 diabetes. So type 1 diabetes, as we know, is caused by autoimmune attack and destruction of insulin-making cells in the pancreas. There is some element of increased genetic risk, and then unknown environmental triggers which cause immune activation and response, leading to autoimmune attack against the insulin-producing cells in the pancreas. The type 1 diabetes antibodies that we can check in the lab are markers of this autoimmune attack. We currently can test 5 antibodies, and these antibodies may be present months to even years before a clinical diagnosis of type 1 diabetes. The beta cell decline, again, is gradual over time. We define stage 1 type 1 diabetes as individuals who have 2 or more positive antibodies, but with completely normal glucoses. These individuals in stage 1, within 10 years, have a 70% risk of progression to clinical type 1, and over their lifetime, at 100% risk of progression. And that's why, again, it is considered stage 1 type 1 diabetes. As beta cells continue to decline, patients progress to stage 2. So again, stage 2, 2 positive antibodies, but also now patients are starting to have some abnormal glucoses as well. At this stage, they again are still pre-symptomatic, but do have abnormal glucose tolerance and abnormal blood sugars. As they continue to lose more and more beta cells, finally they reach stage 3, which is what we typically see patients in the past present with usually with signs or symptoms of high blood sugars, and they meet the ADA diagnostic criteria for diabetes. And usually at stage 3 at this time, they also will need to start insulin as well. Next slide, please. So now that we know that antibody screening is an option and is very helpful for predicting progression, the question is, well, who should we be screening? So we know that individuals who have a first-degree relative with type 1 diabetes have a 15-fold increased risk of developing type 1 themselves. However, 90% of those with new onset type 1 actually have no family history of type 1. The current clear recommendations for screening include those with a family history of type 1 diabetes and those with a personal or family history of autoimmune disease. There is also a movement towards more general population screening, again, given that 90% of those with new onset don't have a family history of type 1. And this is something actually in Italy that they've recently started to promote is general population screening. So that's probably going to be recommended in the near future. Once we know who we should be screening, the question is, well, what timing should we use? So really the youngest that we should be doing antibody screening is at age 1, particularly for individuals in a high resource settings like us here in New Jersey. If an individual is in one of those, again, risk categories necessitating screening, we would recommend repeating antibodies annually if they're initially negative for the highest sensitivity. However, in lower resource settings or in families where they don't want to do annual screening, there are some in families who are not able to do the annual screening or in lower resource settings, there are some optimal screening windows. Again, screening once between ages 1 to 3, if negative, again, age 4 to 6, and then if negative, again, ages 9 to 11. And again, that increases the sensitivity if at least you are periodically checking during these windows of time. So what are the logistics of doing this screening? So here's pediatricians where we really need your help. Yes, patients can certainly get antibody screening through various research studies. TrialNet is one research study. This, however, is only open to those who have relatives with type 1 diabetes. Another research study is called ASK. This is a general population screening program. For both of these programs, you have the option of getting a blood draw, or they can send a kit to your home to do a finger poke testing. And then, of course, if that's positive, you would need to confirm with blood work. So that is a benefit of those research studies. In addition, these antibodies are available in commercial labs like Quest and LabCorp. So increasingly, we are seeing that the pediatricians who know these patients best are ordering these antibodies and then referring to endocrinology if there's a positive antibody and or, of course, if there's an abnormal hemoglobin A1C. So we've put together a sheet with some additional information for pediatricians, including antibody names, test codes, billing codes, and follow-up guidance for LabCorp and Quest. Again, the 5 antibodies that are currently available commercially are GAD, IA2, zinc, insulin, and islet cell. And we always recommend getting an A1C and CBC at least with this initial screening as well. So what happens if you're a pediatrician and you test someone and they have a positive antibody and you send them over to the endocrine office? Well, again, we are doing the confirmatory testing, and then we are staging what stage of type 1 diabetes they're currently at, and then also providing continuing monitoring and diabetes education. So how do we stage and monitor? The gold standard is an oral glucose tolerance test for staging. However, of course, that's very time intensive, and most kids really don't like that. Who does? So more frequently, we're doing staging and continued monitoring with serial A1Cs, capillary or venous glucoses, as well as continuous glucose monitoring as well. So this is just an example. It's a nice algorithm from the ASK study, again, one of those antibody screening studies, showing how the frequency of continued monitoring for those who are either single antibody positive or 2 or more antibody positive. And I won't go through all the fine details here, but major points being that those individuals who have positive antibodies when they're younger often will progress to clinical type 1 more quickly. So they especially require more frequent monitoring versus older individuals. And again, you can see that the monitoring can involve A1C, CGM, glucose monitoring, or OGTT. And so a lot of that will depend on availability, family preference, shared decision making in terms of what's the best way to monitor. Next slide, please. So we have this patient and we're monitoring them for progression, but what else can we do for them? What can we offer them? So we can certainly, if they're interested, connect them with clinical research studies, and actually Breakthrough T1D, formerly JDRF, has a really nice database of type 1 clinical research trials currently recruiting. So that, again, would be open to them if they're identified as having early type 1. In addition, now we have an FDA-approved treatment that delays the progression from stage 2 to stage 3 by 2 to 3 years. And currently it's only available and approved for individuals ages 8 and older. However, end of April, it's undergoing expedited FDA review for ages 1 and older. As you can see here, this is an example of eligibility criteria for teplizumab. Again, currently they need to be 8 or older with 2 or more positive antibodies and evidence of dysglycemia, either again with elevated fasting glucose or postprandial glucose, or A1C, for example. So how does teplizumab work? So teplizumab is an anti-CD3 monoclonal antibody. It binds to the CD3 cell surface antigen on both CD4 and CD8 T cells. It deactivates autoreactive T cells against the beta cells. Logistically, it involves a daily IV infusion consecutively over 14 days. So it is time intensive. And even, again, it's we are getting it covered by insurance. However, the price, I believe, is close to $190,000 or so in terms of for the healthcare system. Many patients tolerate it well. There are, of course, like with any medication, potential side effects that are closely monitored for. Those include cytokine release syndrome, which is a systemic inflammatory response due to rapid large cytokine production that can present with fever, headache, nausea, fatigue, muscle or joint pains. Patients can also experience lymphopenia, neutropenia, anemia, or thrombocytopenia, elevated liver function testing, or rash or hypersensitivity reactions. Given the excitement and really what we can do, if we detect individuals early and monitor them before they develop clinical type 1, we're very excited here at Hackensack in the spring 2026. So to be planning to launch an early type 1 clinic to particularly monitor and educate these patients. In addition, teplizumab was recently approved on the HMH formulary, and we're currently working in the final steps of implementing this so it can be delivered within our hospital system. Thank you so much. It was great to speak with you today.
Okay, so I'm going to change gears a little bit. My name is Alexa Durante, and I'm going to be discussing evaluation and management of precocious puberty. Here are our objectives for the day. And I'm going to start us off with two cases. So a case on the left, case 1, is an overweight 6-year-old girl who was referred to our endocrine clinic for evaluation of body odor and pubic hair for about 4 months. When you perform her exam, you notice she has Tanner 1 breasts and Tanner 2 pubic hair, and her DHEAS level was mildly elevated. For case 2, we have a 5-year-old girl who again was referred to the endocrine clinic for evaluation of breast development. When you ask a history, mom says she had menarche at 11. And when you look at the child's growth chart, it looks like she's had an accelerated growth pattern over the last year. When you do her exam, you notice that her breasts are Tanner 3 and her pubic hair is Tanner 2. So we'll circle back to these at the end. So when we think of puberty, we immediately think of the hypothalamic pituitary gonadal axis, or the HPG axis, and when it gets activated. So it typically gets activated in 3 phases: the fetal phase, the neonatal phase, and then the classic one when a child transitions to an adult. And for the sake of time, I'm only going to focus on the 3rd phase. So when we think of the initiation of the HPG axis at the timing of puberty, this picture here on the right is a very simplified but nice way to think about it. So when we are in pre-puberty, there are several neuropeptides that are working at the level of the hypothalamus that are actually preventing other neuropeptides to preventing the progression into puberty. And so prepubertal individuals will have very high levels of MKRN3, preventing GnRH from rising. When it's time to transition into puberty, MKRN3 will actually lessen, and kisspeptin, which is kind of the key neuropeptide here, will rise, and it acts as what we call the pulse generator to allow for GnRH to be released in a pulsatile fashion. And when it does this, it then further leads to stimulation of both LH and FSH. For girls, FSH will stimulate ovarian follicle production, and in conjunction with LH, it will lead to the production of estrogen and eventually stimulation leading to ovulation. For boys, FSH will lead to spermatogenesis, and LH will stimulate the Leydig cells to produce testosterone. I just want to point out that kisspeptin is so critical to this whole mechanism that individuals with hypogonadotropic hypogonadism actually have been found to be deficient in kisspeptin. So when we think of normal puberty, this is one of the many definitions, right? But it's a biological process that represents the development of secondary sexual characteristics and attainment of reproductive capacity. This is all influenced by genetics, metabolic, environment, ethnic groups, right? Geographic and economic factors. For girls, normal puberty can begin as early as 8 through 13 years old. And for boys, everything kind of happens a year later, so anywhere from 9 to 14 years old. For girls, clinically, you'll see thelarchy, which is breast development, followed by pubarchy, and lastly, menarche. Girls will have their growth spurts between Tanner 2 and Tanner 3 staging. For boys, their first sign you're going to see is actually testicular enlargement, followed by pubarchy, and lastly, penile enlargement. And again, boys will have their growth spurts a year later, so usually between Tanner 3 and Tanner 4 staging. And I put a picture of our orchidometer here on the side because us endocrinologists truly love them, and we use them when we assess all our male patients. So when we define precocious puberty, we think of it as secondary sexual characteristics in girls less than 8 years old and in boys less than 9. A study done in the mid-1990s looked at about 200 providers across the US, simply who evaluated girls for puberty based on their physical exams. And they had a pretty large sample size of about 17,000 girls, most of who were white. Smaller subset, 10% or so, were African American. And what they saw was that at 7 years old, about 27% of African American girls seemed to have signs of puberty, breast development, or pubic hair, whereas a smaller subset, about 7% of white girls had this. As they continued to monitor them, at 8 years old, about 48% of African American girls had signs of puberty, whereas 15% of white children started to progress through puberty. So this kind of led to a conversation in the pediatric endocrine world of whether the criteria for precocious puberty should be changed or adjusted. And so the proposal was, should it be defined as less than 6 years old in African American girls and less than 7 years old in white girls? And so a lot of this had to do with, race and ethnicity and whether that really played a role in the timing of puberty for children. More recently, in 2022, there was a paper published that essentially said, race is a social construct and it may be inadvertently being used as a proxy for other factors that might be a reason for earlier puberty, things like obesity, environmental exposure, any psychological stress, or racism itself. And so ultimately it was decided that, race has no real biological or genetic basis, but rather maybe just keeping in mind the individual you're assessing and evaluating. When we think of precocious puberty, we can divide it into two main types. So we can think of central precocious puberty or peripheral. When we think of central precocious puberty, it's the true activation of that HPG axis, right, happening at an earlier time than it should. So GnRH will rise, and that will then stimulate FSH and LH to stimulate the gonads to produce these sex steroids. And so we classify this as gonadotropin dependent. Now, this differs from peripheral precocious puberty, where there's going to be a rise in these sex steroids, but it's not under the control of the hypothalamus or the pituitary gland. And so there will be excessive endogenous or exogenous sex steroid production. And so we classify this as gonadotropin independent. Overall, true precocious puberty is very rare. It does happen more often in girls at 0.2% compared to boys at 0.05%. But in general, it doesn't happen often. If we do see a boy with true precocious puberty, it is more common for them to have a pathological cause for this. So when we think of etiologies for central precocious puberty, we can divide it into two categories: CNS lesions or non-CNS lesions. So thinking of CNS lesions, right, hypothalamic hamartomas, arachnoid cysts, hydrocephalus, genetic conditions like NF1 or tuberous sclerosis, septo-optic dysplasia, any kind of Chiari malformations, any tumor, any post-insults to the brain, whether that's perinatally, infectious, trauma, radiation, granulomatous disease, or even CP. And then for non-CNS lesions, right, more times than not, I think we kind of land on idiopathic and unknown cause. But other things that should be considered include endocrine disruptors, as well as genetic changes. So I had pointed out those neuropeptides at the hypothalamus, right? And so if you have gain or loss of function with these, it can trigger central precocious puberty. For peripheral precocious puberty, again, we can divide it into systems, right? So boys, girls, or both. For boys, you want to think of CNS or non-CNS lesions, right? Testicular tumors, either Sertoli cell or Leydig cell tumors, androgens being secreted by the adrenal glands, and a kind of unique genetic condition called familial testatosicosis. For girls, you want to think of ovarian cysts, also ovarian tumors such as granulosa or thecal cell tumors, or also any estrogen that's being released from the adrenal gland. And for both sexes, you want to consider McCune-Albright syndrome, severe hypothyroidism, exogenous sex steroids, or CAH. And I just briefly want to touch and talk about lavender and tea tree oil products, because as endocrinologists, we do ask about this in our history. There's not so much evidence base to support it, but rather a lot of reports. So in the early 2000s, it was boys who had gynecomastia and girls who had premature thelarchy who had been exposed to these products did demonstrate regression once they were removed. And so the thought here is that these oils could have estrogen or anti-androgenic effects leading to these clinical findings. Of course, it's very difficult to establish causality, right? We don't have comparison groups. These are just reports, and we can't really take into account other factors that could be causing this gynecomastia or breast development, but it is important to ask and consider. Okay, I'll transition a little bit now to other pubertal variants, which truthfully, we probably see more often than true precocious puberty. So premature thelarchy is defined as isolated breast development that's usually happening prior to the age of 3 years old. If you look at the growth charts, these individuals don't have an increased growth velocity, and they have no other secondary sex characteristics on exam. If you actually monitor their breast development over 4 to 6 months, it's either stable or it might even regress. And this differs from true central puberty, where you're going to see progression of breasts. Possible mechanisms or causes for this include an unsuppressed HPG axis, possibly a small like ovarian cyst that releases estrogen that causes this increase in breast development, exogenous estrogen-like exposures, or of course, idiopathic causes. Next is benign pubic hair of infancy. So this often presents under the age of 12 months old. There's not many studies on this, and so because of that, we're not sure exactly how often it happens. But a case series that I often refer to that took place between 1999 and 2004 looked at 11 infants who only had pubic hair and no other signs of premature sexual development. There were 6 males and 5 females, and their average age was 2 to 9 months old. And when they looked exactly where the hair was located, they saw that the males had hair localized on their scrotum, which this differs from typical pubertal hair patterns for boys, which would be usually on the base of the penis first. And for the females, they saw 3 who had hair on the labia majora, which is more of a typical pubertal hair pattern, versus 2 on the mons pubis. Looking at their race and ethnicity, 5 were Black, 2 were white, 1 was Hispanic, and 2 were not categorized. And most of these infants were full term. They reportedly had no exposures to any exogenous hormones, and they were not taking soy formula. And we ask about soy formula because there is some thought that soy could mimic estrogen. Looking at laboratory tests, 2 did have elevated 17-OHP levels, but those happened to be the 2 preemies, and everyone else's testing was normal. Unfortunately, they didn't have the best return rate, but 36% of the infants followed up. And what they found was that these infants had completely normal growth velocities, and the pubic hair tended to resolve anywhere from 10 to 12 and a half months of age. So again, not completely sure why this is happening. Possibly an increased sensitivity of hair follicles to androgens, or possibly a presentation of mini puberty of infancy, which is a normal stage of puberty as an infant. So not really sure. Obviously, this isn't the best study, right? There are weaknesses, not the best follow-up rate. It was a retrospective chart review. These patients were referred to a clinic, a specialized clinic, right? But at least it gives us some guidance and some reassurance when we see these patients. Next, I'll talk about premature adrenarche, which I think by far is probably what we get referred more than true precocious puberty. And this happens between the ages of about 5 and 8. And these children are coming to your office and the parents are complaining of either axillary hair or pubic hair, body odor, or acne, right? And the thought behind this is that there is an isolated maturation of the zona reticularis. So if we think about the adrenal cortex, the third layer, the reticularis, which makes the androgens, is just maturing a little bit sooner than it should. And if you check these individuals' labs, you're going to see a mild elevation in their DHEA and DHEAS levels. There is an association with being born SGA. And what's really important to counsel these parents is that their child is at risk for metabolic syndrome in the future, and girls may be at risk for PCOS. Okay, and lastly, I'll touch on premature menarche. So this is defined as isolated vaginal bleeding in girls under the age of 8 who have no other signs of puberty. It may be 1 or a few cycles of bleeding. And if you check their labs, their gonadotropins are completely prepubertal. If you look at their growth chart, they have no growth acceleration. If you check a bone age, it's normal. There's no advancement. And if you choose to do a pelvic ultrasound, it's also completely normal. It is a diagnosis of exclusion, so you have to rule out all other causes of vaginal bleeding, such as abuse, foreign bodies, tumors, or infections. But usually this is just an idiopathic event that self-resolves, and these girls will normally progress through puberty at a later time. So if you're seeing a child and you're thinking they're in early puberty, you want to take a very detailed history and perform an appropriate physical exam. So you want to assess the onset of these findings, the tempo, and definitely the sequence in which they developed. You want to ask the parents' family history. When did mom have her period? Try to get from dad when he went through puberty. You want to ask neurological symptoms to see if this is a CNS-related cause, right? So headaches, seizures, visual changes, abnormal behavior, inappropriate laughter, any polyuria, polydipsia. You want to ask about prior head trauma, CNS infections, or if the child's ever been treated for a brain tumor with surgery and or radiation. And when you perform your physical exam, you want to try your best to do a thorough neuro exam, and then you obviously want to check for signs of puberty. So you're going to want to look for acne, axillary hair, breast development, pubic hair, testicular enlargement, and clitoromegaly. For skin exam, you're going to want to look for any caveolae macules, neurofibromas, or bony deformities to suggest possibly an underlying genetic cause for earlier puberty. And I do want to point out that both breast and pubic hair tanner staging don't have to be the same. So you definitely can have a tanner, 3 breast and a tanner 2 pubic hair. So you can assess them differently. Okay, so if you're thinking that your patient might have precocious puberty, what kind of testing do you want to do? So in terms of laboratory tests, you're going to want to obtain 8 a.m. gonadotropins, so LH and FSH, and then the appropriate sex steroid. And you want to order these using ultrasensitive assays, right? And so that's going to detect a really small number or value. And that's critical because that's how we define if someone's in puberty, right? If your LH level is greater than or equal to 0.3, that is pubertal. Similarly, if your estrogen or testosterone levels are greater than or equal to 20, that's usually consistent with puberty. If you think might be something else going on, you're going to want to check adrenal androgen levels, right? DHEAS, possibly a 17-hydroxyprogesterone. That one also is time sensitive and best checked at 8 a.m. If you think this might be severe hypothyroidism leading to an earlier presentation of puberty, you're going to want to check TFTs. And if you're concerned for possibly an underlying tumor, you would consider AFP or beta-HCG levels. So let's say you check these labs and they come back that the child is not in puberty, but there seems to be a large discrepancy between what you're seeing and the lab tests, right? At that time, we can perform a loop light stimulation test. Protocols kind of vary depending on where you practice, but essentially the child would come in, you would get baseline LH-FSH and sex steroid levels. They would be given a sub-Q injection of leuprolide, which is GnRH, right, to stimulate the HPG axis. And then you're going to measure their gonadotropins. Again, the timing kind of varies in the length depending on where you practice. And then usually the next day they'll come back in for the sex steroid measurement. And again, this is just kind of another tool to help you decide if someone might be in puberty or not. So if their stimulated LH level is above 5 to 7, their sex steroids are above 50, or their LH to FSH ratio is above 0.66, does usually suggest central precocious puberty. If the LH and FSH levels are suppressed, then you should be thinking, is this peripheral precocious puberty? Is there another source or a reason for the high levels that you previously saw? And if the LH to FSH ratio is less than 0.66, you can feel reassured that probably the child won't progress through puberty, or is it a presentation of one of those benign variants like premature thelarchy? Additional testing can include a bone age, which is helpful, right? So if you check a bone age and the chronological age is younger, or their bones appear advanced, more than 2 standard deviations, that can be seen with precocious puberty. A very unique presentation would be if the bones are delayed, but clinically you're seeing the child in early puberty on exam. Then you want to think of thyroid hormone deficiency, which is a very unique syndrome called Van Wyck-Grumbach syndrome. Bone ages are great because they can aid in predicting adult height, but it is important to note that in central precocious puberty, they might overestimate the final adult height, so it might not be as exact. Further imaging that you'd want to consider is an MRI, right? So for any boy that you see with central precocious puberty, they're definitely going to get an MRI, and that's because of what I said prior, that more times than not, a boy with true precocious puberty is usually pathologic, or more times pathologic. If you're seeing a girl with any neurological abnormalities, she should get an MRI, and definitely any girl less than the age of 6. Depending on the provider's practice, some might choose to just perform MRIs on all children who come in with central precocious puberty. In terms of ultrasounds, these are kind of used as an adjunct to the evaluation, but not diagnostic. So for central precocious puberty, if you did an ultrasound, you may see larger uterus or ovary volumes. You might see an endometrial thickness, right? But again, this could kind of overlap with these benign variants that I shared with you. And so it's not diagnostic, but just could kind of support what you're seeing clinically. In regards to testicular ultrasounds, these should be performed if you perform an exam and the testes appear unequal in size. Okay, so when we treat central precocious puberty, right, we should have some main goals in mind. We want to slow the maturation of the child, of course. For a girl, we want to prevent early menarche from happening. And we definitely, I think the main thing here is want to preserve their final adult height, right? So as a child goes through puberty and they're exposed to the sex steroids, that does lead to closure of the growth plate. Some children will have slow progression through puberty and may not actually need treatment, but it's hard to know who that will be. Other things include the psychosocial aspect of going through puberty, right? A 5 or 6 year old shouldn't experience that. And then the last point is to relieve parental anxiety. And so we do this using GnRH agonists. And so, like I said previously, right, GnRH is released in a pulsatile fashion that eventually leads to puberty initiation. If we administer it in a steady concentration rather than pulsatile, then we're actually going to lead to downregulation of these receptors and ultimately suppress the HPG axis, which is our goal. When we think of treatment outcomes, right, most studies have shown that when you treat a girl with central precocious puberty under the age of 6, they have the greatest gain in height. There is a little bit of a gray zone with treating between the ages of 6 and 8 and not really sure how much benefit they get. The male data is more limited just because in general there's a smaller population of these individuals. And again, like I said before, height prediction isn't great with central precocious puberty. So it's really hard to kind of counsel if we suppress puberty, how much height an individual or a child will gain. Okay, so how do we give GnRH agonists, right? There are 2 main ways, either implants or injections, right? So the Serelin implant is placed by our surgery colleagues. It's approved for as young as 2. It's usually placed right in the anterior aspect of the upper arm, and it can last for about 1 year. The injections are given a bunch of different ways: 1 month, 3 month, 6 month formulations. This is just a conversation that you're having with the family and what they think is best. Main side effects that we counsel about: local reactions, pain at injection sites, subcutaneous nodules, possibly sterile abscess formations. You do want to counsel girls that after their first injection or just starting the medication, they may have vaginal bleeding and spotting. And this is just because you're giving like a high dose of this GnRH that transiently leads to an increase in LH and FSH and then estrogen, but then with time it's going to drop as the receptors decrease. There is also the concern that maybe if we go the implant route, there's breakage or difficulty localizing the device when you go to take it out. Long-term effects, there is conversation that if we're suppressing puberty, right, we are decreasing their height velocity, usually to a prepubertal growth rate. So some studies have looked at adding growth hormone into treating these individuals, but there's definitely mixed results on that. There's a question on if GnRH agonists are leading to obesity. Again, not great research, more is needed. But one that we definitely counsel about is decreased bone mineral density, right? But we do know that this is completely reversible. So once you stop the medication, the bone mineral density improves. And we just advise that these children continue on an appropriate diet with calcium and vitamin D and continue to exercise regularly. In terms of monitoring, so we like to see these children every 3 to 6 months to follow and make sure that their puberty is actually being suppressed. So clinically, we'll assess their Tanner staging, their growth velocities, and every year we'll check bone ages. Checking labs is controversial and kind of based on personal opinion. When do we stop the treatment, right? So the thought here is maximum height gain for girls happens at a bone age between 12 and 12 and a half, and for boys, 13 to 14 years old. But it's really a conversation that you're having with the family and with the child, right? Are they ready to resume puberty with their peers? Are they feeling a certain type of way and that they want to, have exposure to these hormones now? So after we decide to discontinue the medication, when will the HPG access resume, right? So for girls, kind of variable. Their periods can come anywhere from a year and a half plus or minus half a year. If a girl had their period before they started it, they tend to resume it faster. Again, less data for boys, but usually they resume their Tanner stage within 6 months of stopping the medication. Okay, so now we're back to our 2 cases. Just to recap, so for case 1, this was an overweight 6-year-old girl who came to our clinic for body odor and pubic hair for 4 months. She had no breast development, but she had Tanner 2 pubic hair and a mildly elevated DHEAS level. So her likely diagnosis is premature adrenarche, right? Next steps, things you want to do. You can observe this child, but the main thing, like I said before, is you definitely want to discuss the future risk of metabolic syndrome and possibly PCOS. For case 2, again, just to review, a 5-year-old girl who had height acceleration and Tanner 3 breasts and Tanner 2 pubic hair. So this does look like true precocious puberty, right? She definitely deserves an evaluation, at least with morning labs and a bone age, plus or minus a pelvic ultrasound. Okay, so just some small take-home points. Younger children presenting with precocious puberty is concerning and definitely deserves an evaluation. If you obtain morning gonadotropins and your LH level is above 0.3, in conjunction with secondary sexual characteristics, this does suggest central precocious puberty. Starting a GnRH agonist at a younger age does tend to show the greatest benefit in terms of height potential. Thank you guys so much. We're happy to take any questions.
Dr. Tell, if you want to elaborate on anything you wrote in the Q&A, you're welcome to.
Sure. There was a question about FDA approval for teplizumab. It is currently approved ages 8 and older. Again, at the end of April, it's slated for expedited FDA review for ages 1 to 7. And then again, there was a question about someone, a 9-month-old who has a 26-month-old sibling with newly diagnosed type 1, and a question about screening the sibling, the 9-month-old. So in general, we would start screening at age 12 months. Now, given how young their sister was at 26 months of being diagnosed with type 1, there is a decent possibility that the sibling, and then now this 9-month-old, have a higher risk HLA genetic profiles for type 1, and so and could get it, when they're quite young. And so we would definitely consider antibody screening every 6 to 12 months, particularly when they're young. In addition, theoretically, you could get considered, also assessing their genetic risk beyond antibodies to further stratify their risk. Currently, HLA testing for type 1, really I've seen more done in the context of research studies. I know in Quest and LabCorp, they have the celiac HLA testing, which is commercially available. The celiac and HLA testing does include some of the higher risk type 1 HLAs. So you could potentially do that commercially, but again, I'm more used to seeing that within the research setting.
Yeah, so Shoshana, Is there a recommendation to check every child that has Hashimoto thyroiditis or celiac disease?
Yes, exactly. So because they have a personal history of autoimmune disease, it is recommended to screen them. And again, ideally in high resource settings annually. So that's something definitely a place to start in addition to siblings of really increasing our screening rates.
Thank you. I just wanted to give a few more minutes for folks to trickle in any questions, but I just want to take a moment to thank you, Dr. Durante and Dr. Tell, for giving us such a impressive presentation, which I think will be really valuable for those who joined. We just got another question from Bonnie. Dr. Tell, if you'd like to ask it about, what about type 1 diabetic for testing? If there's no other questions at this point, I think we're going to close out. And as I mentioned in the chat function, you will be getting a recording from this presentation. And I really appreciate those who were able to join, as well as the partnership with the NJAP. So thank you, and look forward to next month, our presentation featuring pediatric urology. So thank you so much for those who were able to join today.